As COVID-19, civil unrest, and economic and political factors contribute to greater isolation and the potential for increased deaths of despair, linking healthy bodies and healthy minds is a practice we all must follow. Welcome to Advancing Health, a podcast brought to you by the American Hospital Association. I'm Tom Hedderly, Senior Writer for AHA. In part 2 of a 3-part series, Rebecca Chicky, Director of Field Engagement and Behavioral Health Services at the AHA, is speaking with Minnie Matthews, Director of Global Behavioral Health at Parkland Health and Hospital System, and Dr. Pedro Fernandez, Co-Chief of Psychiatry at Parkland and Assistant Professor of Psychiatry at UT Southwestern Medical Center.
Welcome to another podcast in the American Hospital Association's ongoing series of podcasts where we focus on important issues facing clinical leaders and behavioral health providers. I'm Rebecca Chicky, Senior Director of Field Engagement and Behavioral Health Services at the American Hospital Association. I'm joined today by Minnie Matthews, Director of Global Behavioral Health at Parkland Health and Hospital System, and Dr. Pedro Fernandez, Co-Chief of Psychiatry at Parkland and Assistant Professor of Psychiatry at UT Southwestern Medical Center. Today, we are talking about sustainable and practical approaches to integrating physical and behavioral health care in primary care settings, the emergency department, and inpatient settings as well. To get us started, Ms. Matthews and Dr. Fernandez, please tell me a little bit about yourselves and your role at Parkland Memorial.
My name is Minnie Matthews. I'm the Director of Global Behavioral Health here at Parkland Hospital. I have been here since 2002 and have really grown to love our Department of Psychiatry here. Started off with management and then moved into the director role. The Global Behavioral Health Program is a new program that we're expanding, and with efforts of our behavioral health team, we are growing and moving into the community as well.
Hi, my name is Pedro Fernandez, and I'm the Co-Chief of Psychiatry here at Parkland. I've been at Parkland for the last 3 years. My formal training is in Consultation Liaison Psychiatry, which works on the interface between psychiatry and other medical subspecialties. So my passion has always been about the integration between physical and mental health. And I've also been working very closely with Minnie Matthews regarding our integration of behavioral health services within the hospital and our clinic.
Thank you, Dr. Fernandez. That is a nice integration into the next question. Ms. Matthews, how did Parkland get started with the plan to integrate physical and behavioral health care, particularly related to suicide risk reduction?
Thank you, Rebecca. It began with the recognition of the increase of suicide rates in the nation and the development of the Quality Improvement Project focused on how our hospital can respond to this epidemic. Prior to this, we had an integrated behavioral health program in our community health clinics, but did not have a formalized suicide or depression screening plan anywhere else in the hospital. After the success of our suicide program, it eventually led to further increasing the integration of behavioral health across the hospital system, and then an eventual development of our global behavioral health program.
So, Dr. Fernandez, are there key factors that helped you succeed in implementing the integration of physical and behavioral health?
Thank you, Rebecca. So the key to any good, successful program in behavioral health integration, well, regardless of whatever is the program, whether it's our suicide screening program or our behavioral health integration within primary care, the tenets and the factors that make it successful is the same. One is leadership engagement. You definitely want to make sure the leaders, both in the hospital, in the individual clinic settings, are aware and invested in the program, because you'd want them to help continue to sustain and reinforce the program in all the various clinical sites. Second, you want to have staff buy-in. You want to make sure the staffer is aware of the importance of the program and why we're doing it. You know, I don't think any program is successful when staff just feel obligated to do the work. It's important that they know the importance of the work that they're doing and that they're as important as the leaders in the success of the program and its outcomes. Third is the development of workflows and intervention plans. You want to make sure at the very beginning you have drafted out a plan of how the system is going to be implemented, making sure that you're looking at it from the perspectives of both the leaders, the patient, and the staff implementing the program, because that will give you a good sense of being able to troubleshoot any problems that kind of arise. It also is important in informing the processes that staff will follow. Fourth is creating a training system for both staff and providers involved in the program. It's very important to have that initial training in the beginning, but you also need a system of continued education, because you'll need that continued education both for new staff members coming into the program and also to sustain the education for the providers within the program. Then you also need a system of monitoring compliance. How is the program doing? What are the outcomes you're looking at? Making sure you have that system of monitoring. That way you could report back to both leadership and staff to see how things are going. Lastly, you want to have a good idea of the resources you're using. What are the resources you're allocating to the program? Is it borrowed? If it's borrowed, is that sustainable? Making sure that you have that good sense of you have the program, now who are your team members? How can you keep them in this role? And how can you sustain those resources despite maybe fluctuations within the hospital and the clinic setting? That last part could be a little bit challenging, but also a very important aspect to keep in mind at the very beginning.
Thank you so much, Dr. Fernandez. I love the number of key factors that you described, because all of them working together is what I believe has lifted your program to the success that it's had. So thank you for articulating all of that. However, I bet you learned a few things as you developed and rolled out this process. So Ms. Matthews or Minnie, could you share those lessons that you learned and what you would do differently?
One of the things that we learned about was our infrastructure around IT considerations. One thing that we did was create hard stops for discharges for high-risk patients. That was an important pause that we needed to have to make sure that patients did not fall through the cracks. We also limited access of clearing flags. The other thing that we did was the importance of ongoing training for staff regarding the program. As new behavioral health staff members start, nursing members, and all those involved in the workflow, it was important that there was an ongoing training that was developed. And as Dr. Fernandez mentioned, building a system to monitor outcomes. We did provide volume management for the entire system, but future monitoring includes connections to mental health resources and monitoring ED recidivism. As Dr. Fernandez mentioned, allocation of appropriate resources. Initially, due to staffing and budgetary constraints, the team did not have the ability to provide immediate interventions and assist with warm handoffs, and that could have taken several days after the initial intervention. As Dr. Fernandez mentioned, education and support behind these programs need to be consistent, keeping up with the momentum of teaching and new leadership buy-in as staff turned over. So developing outcome variables and connections to resources for quality improvement and clinical outcomes was another lesson that we learned.
Excellent. And thank you for sharing that, because we all need to know that our work doesn't have to be perfect the first time out of the gate, and that we can learn those lessons and improve upon them. So now that you are up and running, what are some of the approaches you use to sustain the work and continue to support the team, Dr. Fernandez?
So there's a lot of ways to kind of view this about sustaining the work and supporting the team. I think if we're looking at it at a larger institutional level about the sustainability of a program, one, you definitely want to make sure that that leadership involvement that you foster at the very beginning continues on with the program. So definitely reporting back on the outcomes and the improvement of the programs to leaders is very important, because you want to be able to sustain that engagement. Second, at the larger level, you definitely want to make sure that you have a system of advertising the program and the positive reputation it has in impact on the hospital system. Because again, that helps provide further engagement with the staff and other providers working in the program. Again, showing the importance of the work. At a smaller level, you definitely want to have systems in place to be able to sustain both staff and provider involvement. Let's say, for example, within our integrated behavioral health program, having a system in place for case consultation, monthly meetings, and employee engagement activities are very important. Because again, it solidifies the identity of teamwork, because I probably should have added this at the very top. Teamwork is also a very important tenet of good, successful behavioral health and mental health integration. So anything you could do to sustain that and help form that identity of a team, I think is very important. Finally, one of the important things is continued looking at productivity of the system. Understanding productivity of the system is very important because, again, if we're looking at sustainability of a program, we want to make sure that we're showing the worth of the program. So things like volume numbers, outcomes that Minnie discussed are very important because, one, if you're not able to create a system that is sustainable within its own billing practices, you definitely want to create a system that's sustainable by positive patient outcomes.
Absolutely. As we begin to wrap up, could you both share what's been the biggest surprise that you've experienced as you've advanced this work?
One of the things across our system that we've noticed was the positive impact that it's made on our patients and the positive feedback that we've received from our patients. They have responded so well to our interventions and have become receptive to treatment. That has been an incredible learning experience from us in terms of implementing this screening.
On my end, one of the biggest surprises, actually one of the more pleasant surprises, was how much our programs have developed with feedback from both our patients and our staff. I always consider that very important, but, as we've developed our program, each clinic, each environment we're implementing this integration is unique. So a lot of it has grown and adapted according to our patient and staff feedback, especially as we're looking at fine-tuning our policies, procedures, and workflows.
Thank you so much to the both of you.
Thank you.
Thank you.
This is Rebecca Chicky with the AHA, wrapping up the podcast, Marrying or Integrating Mental and Physical Health, Practical Approaches and Sustainability. Today, we've been joined by Minnie Matthews, Director of Global Behavioral Health, and Dr. Pedro Fernandez, Co-Chief of Psychiatry, both from Parkland Health and Hospital System. Thank you so much.